So in continuation to my mentor's talk, Dr. Ullas Bhatta's talk, where we ended with a new hope to find the new drugs, a new better drugs and better overall survival. This is regarding a new indication of the old drug, abemaciclib, in a new setting, in the adjuvant setting. So I will try to show the results of this new drug in a newer indication. So this is about study called Monarchy. It is about inclusion of a new anti-adjuvant adjuvant drug, anti-hormonal drug, CDK4/6 inhibitor in the adjuvant setting of early breast cancer. The high-risk early breast cancer, we know that very much risk of relapse. My slides are not moving. Yeah. So when we start the treatment in the adjuvant setting, the entire family is worried when the lady or the homemaker is diagnosed with cancer, and they will ask about the chances of cure. And when we see clinically it is early breast cancer, definitely there is a lot of hope in the air and in the OPD room, and there is a lot of discussion of about the hope that will be discussed between the physician and the patient and the family. And after a tedious diagnostic armamentarium and then undergoing chemotherapy, surgery, and sometimes adjuvant radiation when necessary, patient feels the treatment is over and I am cured. But they are not so worried about the hormonal therapy, which many of the physicians will stress that there is no much of the side effects for this hormonal therapy, and they are very happy to continue the hormonal therapy for 5 or 10 years, and they feel they are cured. But we know that majority of the high-risk early breast cancer, they ultimately have relapse. And after relapse, they are so disappointed with all this conversation happened early that the patient will get better. So they are utterly disappointed. So can we do something that can prevent this scenario or postpone this scenario or even prevent this scenario in some of the patients? This is about all this trial that is called Monarchy trial. Can we add better drugs in addition to the standard hormonal therapy to prevent relapse or in fact to prevent the metastasis or even the local recurrence? So this is a drug called abemaciclib. We all know is a CDK4/6 inhibitor, which is one of the potent CDK4/6 inhibitors of all the three, which can act in the brain also. Let us see the trial design graphically. So it is in the early breast cancer. It is a high-risk early breast cancer. Hormone positive and HER2 should be negative, and node should be positive. So what are the groups they have included in this study? If they have 4 positive axillary lymph nodes, they can directly be included in the study. If they have 1 to 3 positive axillary lymph nodes, they should have one more additional criteria to get included in this study. One of it being grade 3, a tumor size greater than 5 centimeters, or Ki-67 greater than 20%. This should be a centrally tested Ki-67 because Ki-67 is usually done by immunohistochemistry, which is subjective to each pathologist, and so it should be centrally tested. And other inclusion criteria in this is even men with breast cancer can also be included. Both pre and post-menopausal women have been included in this study. The previous chemotherapy is not a contraindication, or it is not required also. Anything, both with or without chemotherapy, can be included. And obviously, there should be no metastatic disease. When we see the number of patients enrolled in the study, nearly 5,637 patients with 1:1 randomization. So what are the stratification factors they want to look at? People who received chemotherapy versus who do not, menopausal status, pre versus post-menopausal status, and ethnicity by region. The two arms are abemaciclib in addition to the standard of care endocrine therapy at a dose of 150 milligrams twice daily and endocrine therapy. And the trial is to give 2 years of abemaciclib in addition to the standard endocrine therapy, which can be up to 5 years or 10 years. The primary objective is to look at whether there is any difference at 3 years in invasive disease-free survival. And secondary objective is to look at the distant metastasis, that is invasive distant metastasis-free survival in Ki-67 greater than 20% and overall distant recurrence-free survival the overall survival, which is obviously requires much longer time in the adjuvant setting. Safety, are there any new safety signals? What are the other pharmacokinetic parameters and patient-reported outcomes? We shall see all these criteria in little more detail. When we see the other key inclusion criteria, the patient must have undergone definitive surgery of the primary breast tumor within 16 months of randomization when included in the study. Other important inclusion criteria is the patient, if she or he has undergone chemotherapy or radiotherapy, the side effects should be minimal and they should be less than or equal to grade 1, which means almost they should be asymptomatic. Only then they are eligible to be included in the study. They should have excellent performance status of ECOG 0 or 1, and they should not be having any significant comorbidities, which means all organs should be functioning, there should be no end organ dysfunction, and they should be in a situation to take oral medication. What are the exclusion criteria? Inflammatory breast cancer, if it is diagnosed, it is out of the study. And any history of breast cancer, which is invasive breast cancer in either of the breast, 5 years before in last 5 years, they are excluded from the study. Pregnant women or pregnancy breast cancer, they are excluded, and breastfeeding, they are not included. And any prior exposure to CDK4/6 inhibitors should not be there. And they should not be receiving any other hormonal therapy. And history of syncope of cardiovascular etiology, ventricular arrhythmia, and sudden cardiac arrest, which means the cardiac status should be perfect, and there should be no history of venous thromboembolic event previously, even including in pregnancy. And if patient has received any experimental therapy in the last 30 days, they are excluded. That means they should not be in any other clinical trial before. So these are all the exclusion criteria. And we have seen that the primary objective, because it is adjuvant setting, assessing overall survival is not so easy. It will require quite a time. So the primary objective to see whether we can prevent the invasive disease-free, whether we can achieve the invasive disease-free survival significantly compared to the standard endocrine therapy. Other secondary objectives are, if IDFS is being prevented in high-risk patients of Ki-67 greater than 20%. Because Ki-67, we know, although it is not mentioned in many of the institutional reports which after the biopsy report, but in those with particularly hormone positive in early breast cancer in adjuvant setting, some of the tools which we use to assess whether we need to use the adjuvant therapy or not, Ki-67 is an integral part of that most of the tools. So here also Ki-67 is a must. And disease-free, relapse-free survival is the other secondary objective, overall survival. So patient-related outcomes, there are 4 factors they have looked at. That is FACT B questionnaire and functional assessment of cancer therapy, endocrine symptoms, including thyroid symptoms, diabetes-related and other endocrine symptoms, functional assessment of chronic illness therapy, FACT F questionnaire, which is really an important factor. And EuroQL, EQ5D5L. This is the questionnaire they have used to assess the quality of life parameter in the patients who are receiving abemaciclib. Obviously, safety signals were assessed. So in ESMO 2020, an interim analysis was presented. And when we see the distribution of patients, they are almost equally distributed, 2,800 in each group, abema versus endocrine therapy. This invasive disease-free survival, when done at the interim analysis, this is a planned interim analysis, which is done at 15 months. So at 15 months, it was seen that nearly 12% of patients, they have completed the therapy. Because these patients are being recruited over a span of time. At 15 months, which is the planned interim analysis period, only 12% of patients have completed the 2 years of abemaciclib therapy. But even with the 12%, they have seen that the difference of 3.5% in IDFS rates in those population who have completed the therapy. When we see the absolute numbers, it is 92.2% IDFS in abema group versus 88% in endocrine therapy group. In the same way, one of the important secondary objective is DRFS, that is distant metastasis. 28.3 reduction in DRFS was seen with abemaciclib, When we see the absolute values, 93.6 versus 90.3, which is 3.3% absolute difference at 2 years. So at this point, they have mentioned that it is the first CDK4/6 inhibitor to show significant improvement in IDFS when combined with endocrine therapy. And at this point of 15 months, it has shown some hope that maybe adding abemaciclib will have definitive benefit. So the next analysis was done at 19.1 months, which is the primary outcome analysis, primarily to see the IDFS. And at this point of time, it was seen that nearly 25% of patients who were enrolled have completed 2 years of abemaciclib therapy, and there were 390 events by then. And when we see the 25% reduction with HR of 0.747, which means nearly 26% of events were reduced in patients who are using abemaciclib. In the same way, the 28.3 reduction in the distant metastasis. This is at 19 months. Now in 2021, we have.
So my apologies, sir. You are left with 3 minutes to conclude your presentation.
All right. So in 2021, we have furthermore analysis at 27 months, where nearly 87% of patients have completed 2 years of therapy, and 17% they were dropouts. So they have one of the secondary objectives to see whether there is IDFS benefit in Ki67 high greater than 20%, and it was seen that not only in Ki67 high but in Ki67 low, there is definitive benefit of using abemaciclib. When we see the curve here, sorry for the small figure, there are 4 curves here. So Ki67 low with endocrine therapy, you can see, and with adding up abemaciclib, there is definitive benefit. The curves are really separating from early onwards. And here, in patients who are at high risk, greater than 20% and Ki67 high, abemaciclib is far much higher than those who are using endocrine therapy. They are the people we know at a very high risk of recurrence. And coming to the safety signal, are we very, very happy with the abemaciclib? A little bit doubtful. Why? Because in the first 3 months, it is definitely a test for the patient. And obviously, physician should take care to do a very good counseling. Then after 3 months, patient will be very much comfortable with abemaciclib. When we see the side effects here, grade 1 adverse events, they are 97%, and grade 3 adverse events nearly occurs in half of the patient population when compared to the 14% in only endocrine therapy. And one of the significant side effects is diarrhea, very important side effect that need to be managed. And most of the diarrheal events occur in the first 3 months. And second significant is neutropenia. Majority of this neutropenia will not result in neutropenic fever. And other important side effect that will affect the quality of life is fatigue and obviously nausea. So some of the patient might need antiemetics also, although we are not giving chemotherapy. 17% of patients, they have discontinued abemaciclib due to various side effects, and majority of the discontinuation occurs in the first 3 months. So first 3 months, counseling, talking, assessing patients, looking for the side effects, also including this venous thromboembolism, which is significant side effects. They have seen that it occurs in the first 3 months. So clinical examination, continuous follow-up, counseling, all these are very important in the first 3 months. Diarrhea, venous thromboembolism. Venous thromboembolism occurs at 2.5% of patients. Pulmonary thromboembolism occurs in 1% of patients. And in patients receiving only endocrine therapy, it is 0.1%. So we need to assess the symptoms in shortness of breath, dyspnea, etc. ILD is reported in 2.9% of patients. So first 3 months of abemaciclib needs a lot of support. After 3 months, patient will be very comfortable in continuing up to 2 years. So counseling is important. So this is the repetition of slide where there is 7% difference in cases in terms of benefit of abemaciclib in Ki67 high. So to conclude, abemaciclib plus endocrine therapy, they significantly reduce the risk of developing invasive disease at 2 years and at 27 months of analysis also, particularly in those with high risk disease of early breast cancer. At least this will prevent many of the disease-free events in these patients, and we can prevent the recurrence and we can extend the happy days further. So with this, these are the countries in which monarchy trial was included. However, India is not a part of this. in Americas, European, and Asia Pacific. And with this, I conclude my talk. Thank you so much.